Today we're going to be talking about shockwave lithotripsy, or what we call S-wall. My name is Mark Greenstein. I'm a urologist in Sandy Springs, Georgia, and it's my pleasure to give this little talk today. I wrote this talk, so there's no financial incentive. No one paid me to do this. This is just something I like to do because I think it's important for patient education. And so if patients come into my office, I want to be able to say, hey, listen, I got a video on this if you want to participate and watch and learn about this. So once again, Mark Greenstein, went to Delaware. 1993 is when I graduated. Then I went to Philadelphia College of Osteopathic Medicine in Philadelphia, because there's actually satellite campuses in Georgia right now. Completed my residency. It was a 6-year program between PCLM and Einstein Medical Center in Philadelphia. I practiced in Jersey from 2003 until about 2018. And then I moved to Atlanta, Georgia to join Advanced Urology. I've been performing shockwaves for about 20 years. I'll do anywhere from 30 to 50 cases a year, depending on the year. And so let's talk about kidney stones. Kidney stones are just merciless and they're miserable. And so what are kidney stones and why do we hate them? Because no one likes them. I like them, but no, I don't expect anyone else to like them. So basically, they are a cluster of salts and minerals like calcium oxalate, calcium phosphate, uric acid that cluster up inside the kidney because of an imbalance of any of these salts and minerals. And then a little nidus gets formed, and then the stones start propagating almost like the rings of a tree. So stones don't just pop up. They always start as a little dot, and then they just grow and grow and grow, kind of like a seed up into a big tree. They cause pain, lots of pain. Anybody who's had a stone attack will tell you all about it. And they remember the day. Some people remember the moment. They can tell you the story 30 years later because they know what it's like. They send you to the ER. Boo, I hate the ER. I don't ever want patients to have to go to the ER. But listen, the ER is there for a reason. They're there to get you out of a crisis, and they're there to make you comfortable. They cause infection. Lots of people get infected. We see people where a stone will clog up the urinary system, and then all of a sudden, they start getting fevers, they start getting chills. It's not uncommon. In other words, it's common for me to be called by the intensive care unit because they have someone who's in shock because of a kidney stone. It's part of the business. They cause blood in the urine. Some people, they'll have no symptoms, or they'll get pain and they'll just start peeing blood, and that scares everybody. They cause you to lose work. I'm sure I can go on the internet and ask Google the amount of money that's lost because of people not being able to work and be productive because they're dealing with a kidney stone. They are very good at ruining vacations. I have lots of people that come into my office, say on like a Monday with a fresh kidney stone, and they're like, I'm supposed to go to Florida on Friday. Do you think I can go? And I'm like, I don't think you can. I think you're in trouble. I think you need surgery. And you can go to Florida, but good luck. You'll have to find a doctor down there if you get into a crisis. And they also require numerous surgeries to get rid of them. I had someone in the surgery center today. She required 4 procedures to get rid of her kidney stones. That's how aggressive these things can get and how troublesome they can be. It's not as easy to say, oh, you got a hernia, we'll fix the hernia. Or you need your arthroscopy for your knee, we'll do that. Sometimes it requires numerous procedures. And for the talk, guys, I'm going to ask that we hold questions to the end. There is a chat if you wanted to send me a message towards the end. So what are treatment options for kidney stones? Well, observe them and just hope that they pass. When stones are greater than 5 millimeters, the chances of them passing on their own go down. So the ideal stone would be a 2 millimeter stone. And I'll joke around. I'll say, I want you to go to Six Flags, ride the roller coaster, and hopefully it passes, because just by jarring up the body a little bit, it'll stir the stone up and out it comes. But sometimes stones are small enough that we can just give a medicine. There's a medicine we use called tamsulosin. Tamsulosin helps dilate the ureter. The ureter is on this little picture here. That's the tube that connects the kidney to the bladder. And tamsulosin helps dilate that tube so that small stones can pass like 3, 4, and maybe even 5 millimeters. So what are other options? We shock them. The other situation would be as if a stone is stuck in the kidney, like up here. The patient gets discovered to have a stone, and we shock it before they end up in the emergency room. We can break them with cameras and lasers. That's called ureteroscopy. That's where someone gets anesthesia. We take a camera and we look up into the kidney, and then I play asteroids and I break apart the stone. And sometimes I'll do the sound effects like pew, pew, and we'll break the stones. But then I got to put the dreaded stent in, and we'll talk about the stent later. We can dissolve them. So there are stones called uric acid stones. Uric acid stones are made of a protein byproduct called uric acid. It's the same thing that people, when they get a gout attack, it's uric acid building up in a joint. Well, we see uric acid building up in a kidney. We're able to dissolve those stones, but unfortunately, uric acid stones are maybe 10% of stones. If they're lucky, they're lucky that if they have a uric acid stone, because I can dissolve it. Sometimes stones are so big, we have to go through the back. So in other words, we can't use a camera through the bladder or the ureter. We can't shock it with a shockwave machine. We have to do something called percutaneous surgery, and that requires hospital stay. Sometimes stones are so complicated that I actually have a partner that can do a laparoscopic assisted removal of the stones. In other words, he will go into the belly with a laparoscopic camera, robotic surgery. He will actually open the kidney. It's called the renal pelvis, and he'll scoop the stones up with the robotic arms and then sew the kidney closed. That's for very, very complicated cases where the anatomy is not favorable. Many stones require multiple stages. It is not one and done. All right, so let's talk about extracorporeal shockwave lithotripsy, or ESWL, which we call SWAL. So shockwave is physics. So basically an acoustic sound wave in the form of a mechanical. Now I'm not going to talk about that, but here's a nice little diagram of the math. Here are some we'll call it engineering photos or diagrams of the way sound waves are created. EH is electrohydraulic, EM electromagnetic, PE piezoelectric. We use electromagnetic in our practice, and that's pretty much the mainstay treatment on breaking stones, is that specific technology. So here's another diagram of how electromagnetism is used. Energy is created. The energy is then pinpointed to the millimeter, to where the stone is. The sound waves go through the body specifically to a spot. And then here's a picture of a stone breaking over the amount of shocks. So shocks, it's not like one shock, it's thousands of shocks, up to 2,500, sometimes up to 3,000 shocks. And so here's a nice little diagram of what a stone would look like. And then after 100, 250, all the way up to 2,000, and you can see how it turns to dust. Originally, the shockwave machines were built in bathtubs. And this is kind of what they look like. Look at this, a black and white photo. Who would think of such a thing? And so people would be submerged in a tub because you need the sound waves. You need the water to help with the sound waves to get to the stone. Patients would be put in a bathtub. They're in a bathing suit of all things. They get sedated. So there's your anesthesiologist. And then the sound waves are delivered to the stone under X-ray guidance while you're in this bathtub. Now things are a lot fancier. The machines are mobile. On this diagram here, let's go to the next slide. There is a basin, we'll call it, or a head, and that's what houses the water. So instead of getting submerged, now the water is in this little head or container. The patient lays down on the table. Within this water device is where the X-rays get transmitted up and down and across the body. We have a machine that shows us the x-rays, and on this machine, we can even do ultrasound at the same time, which has been a game changer for us because not all stones could be seen on x-ray. Another little diagram from the company, just talking about how we can use ultrasound and x-ray to help pinpoint a stone. Today, I had a person, the stone was blatantly obvious on x-ray, so we did not need ultrasound, but sometimes we need both. So here's another little picture of kind of like what x-rays will look like. We get to see the stones where the stent is. This is plastic tubing. The coil is what a stent looks like. So let's talk a little bit about what happens during Shockwave. So first, you got to make a kidney stone, right? You got to then find your friendly neighborhood urologist. Some kind of imaging will be performed, whether it's an ultrasound, a CAT scan, an X-ray. Many patients come to us already with a CAT scan performed. In other words, they were in the emergency room because of a kidney stone attack, or they had an ultrasound of their gallbladder, and right near the gallbladder is the right kidney, and lo and behold, they discovered a stone. And so you see these incidental things, and some of these images are already prepared for us, but we need some form of imaging. I like starting with ultrasounds, then progressing to CAT scans. And then if I have a stone that I'm going to be treating with Shockwave, I almost always get what's called a KUB X-ray. KUB stands for kidney, ureter, bladder. We got to schedule you for surgery. So rules of surgery: don't eat or drink anything after midnight. Even if your surgery is at 4 in the afternoon, too bad. You got to fast, because if you come in with a cup of coffee, a glass of water, a Danish, or a donut, you're being canceled. So NPO means nothing to eat after midnight. If you need a sip of water or something, that's fine. If you need to take a little medicine like a Tylenol, please do so. But no food in your stomach or liquids in your stomach. Certain medications need to be stopped before the procedure. And the person who's watching this, you know who you are. So aspirin, blood thinners, non-steroidal anti-inflammatories, that's like Motrin, Advil, ibuprofen, that's actually the same thing. Aleve, which is naproxen, and even some of the new weight loss medications like Wegovy, Wegovy, and whatever they're called. I'm a urologist, I don't deal with that. But those are things that actually slow the stomach down. And so we actually have a protocol that we put into place. So patients have to hold that medicine about a week before their procedure. You need a driver. Someone has to take you home after procedure because Shockwave is performed with anesthesia. We usually give a general anesthesia, so the person is asleep. They are breathing on their own, but there is a device in the mouth to help them with breathing. We'll say it's a little bit deeper than a colonoscopy. On the day of the procedure, you come in, you sign your consent, we mark your side, you go into the procedure room, and then we go find your stone. We're either going to be doing X-ray, we're going to do an ultrasound, sometimes we do both. Then anesthesia comes in, and they're going to start their countdown, and you go to sleep, 10, 9, 8, and then you're out like a light. And then Mike Tyson comes in, and he is going to hit your kidney 2,500 times to break up that kidney stone. Well, not really, but I joke around like that. So for the kidney, we hit the kidney up to 2,500 times. Sometimes I stop a little sooner. So if I'm shocking and I do periodic x-rays along the way, and the stone is gone, I'll stop. Sometimes we have to go a little bit more, but that's only when a stone is in the ureter. The data shows that we can shock the ureter up to 3,000 times. But for kidneys, we stop at 2,500. Procedure takes about 45 minutes. It's not fast because there's a rhythm to it. There's a pause that goes on. So as we do this, we start with a very low energy. We build up the energy every 100 shocks. Then we take a pause. The pause has been shown to help reduce the risk of bleeding. And we actually go slow. The data has shown that the slower you go, the better the stone will break. Years ago, they would shock a stone at like 120 hits per minute. Now we drop it to 70. So it's better for the patient, but it takes a little bit longer in the anesthesia world. You're then going to go home. You're going to drink a lot of water, at least 60 ounces of water. You're going to take some pain medicines, Tylenol, Tramadol, which is like we'll call it a weak narcotic. But sometimes I have to give narcotics like Percocet and oxycodone and things like that. No aspirin, ibuprofen, or ketorolac. Ketorolac is just another non-steroidal anti-inflammatory. It's actually also known as Toradol. It is the big rescue medicine when people have a kidney stone attack. So we actually keep this in our office, and we'll give someone a shot in the tush if they're coming in with a full-blown stone attack with ketorolac, because it's the big rescue medicine. Blood thinners are always a little challenging because we don't want to be cavalier and there's a little bruise going on to the kidney. And then all of a sudden the bruise gets worse because someone goes back on things like Coumadin and Xarelto and Brilinta and all the other blood thinners that are out there. Eliquis is the big one. And so what I personally do is I get an ultrasound within 2 days of the Shockwave. And if the kidney looks healthy, I'll tell the person to resume their blood thinner. We have you strain the urine. This is not absolutely necessary, but it's always nice to collect a fragment so we can send it to the lab and analyze it. What is it? Is it calcium oxalate? Is it calcium phosphate? Is it uric acid? Is it something else? Then the doctor will set up some follow-up image, whether it's going to be an X-ray, an ultrasound, sometimes a CAT scan, and that helps us gauge how the stone volume goes down. If you're starting with a 7-millimeter stone, I want to make sure it's gone. I want to make sure it's all out. So we do X-rays or ultrasounds to make sure. A lot of people will also use tamsulosin. That's also known as Flomax. Flomax is a prostate medication that relaxes the little itty-bitty muscles of the prostate. But those little itty-bitty muscles are the same muscles that are in your ureter. And by relaxing them, it's been shown to help stones pass. And then a lot of people will get what's called a 24-hour urine test, also known as a litholink. And this is a diagnostic test that helps us determine why did you make your stone? Because after all this, who wants to make another stone? I know you don't. I want you to because I want to be able to do my procedures, but I really don't want you to. Making stones is so unenjoyable and so challenging. If I can do anything in our power to help, this is the test that we do to help find out what's the calcium, what's the salt level, what's the uric acid, what's the acid base, so that I can try to put a stop to stone formation. So let's go over some statistics. Success rate is very high. When we do Shockwave in the kidney, which means renal, so kidney stones, it's up to 90% success rate. And the success rate is actually stone freedom at 3 months, not the next day, not the next week, but up to 3 months. That's how long it can take for these stones to clear. And I've had patients take years for the little fragments to work themselves out. That's just what happens. For stones that are stuck in the ureter, the statistics are not as good. The proximal ureter, in other words, the part of the ureter that's the highest or closest to the kidney, is better than the lower part of the ureter. In some people, ureteral stones are not good candidates for Shockwave. For example, like in pregnancy and things like that. And I think I'm going to touch base on that in a second. Number of treatments. Some people need more than one. The average stone treatment is 1.3 shocks across the country. So in other words, some people have a big stone, shock it once, give them a few weeks, shock it again, and the whole goal is so that they don't have to have the dreaded stent. Success rate for Shockwave is higher for smaller stones. Stones that are less than 10 millimeters or 1 centimeter has a success rate of around 90%. Stones that are bigger, the success rate goes down. So if someone comes in with a 2-centimeter stone, that's a tough stone to shock. Can be done, but it's tough. Success rate is also higher for stones that are in the upper part of the kidney than in the bottom. The kidney has gravity. There's an upper, a middle, and a lower pole. So the upper pole, things are a straight shot into the ureter. Middle pole, almost a straight shot into the ureter. Lower poles, gravity. And so the stones are going to sit there. And sometimes I have to have people do these little exercises, if you want to call it like that, to kind of turn their kidney upside down so that they can pass the fragments. And listen, Shockwave is great, but it's got side effects. Everything I do has side effects. The big one is pain. Everyone's going to be sore for a day or two, sometimes a little longer, sometimes a little less. The big one is bleeding. Bleeding usually means that blood has settled around the kidney. Everyone will bleed in the urine. That's just part of it because you're rattling the kidney up. The big issue is bleeding around the kidney, and that's called a subcapsular hematoma. The statistic is about 1 in 500. It definitely happens, but it's not that common, thank goodness. The other big one is that stones can get stuck on the way down. So if the stone, let's say a stone is 8 millimeters, it breaks into a whole bunch of 3 millimeter stones, and then they get stuck on the way down. We actually call that Steinstrasse, which is street of stones, and it looks like a cobblestone on an x-ray. And then there's always a risk of infection. Usually the people at risk of infection are the people who have stents, because when the stent is in, already bacteria is starting to build up in the body. That's common. It's part of the business. So what are some limitations? Stones that are too big, stones that are too dense. There's something called a Hounsfield unit. Hounsfield is Dr. Hounsfield. He came up with a way of measuring density and how something is thicker on a CAT scan. And the denser the stone, the harder it is to break. So I'll sit down with a CAT scan. I'll use the computer program of the CAT scan to measure the density of the stone. Anything greater than 1,000 Hounsfield units, that means the stone is not going to break as well. We can still try it, but the chance of it breaking goes down. Stones on both sides, we cannot treat both sides at the same time. So it is very common to see left and right stones. I usually do the higher burden first, or if someone has symptoms on a side, and then I will go and treat the other side later. Any active infection, we're not going to treat that. That person needs antibiotics and they need to cool down. If you can't see the stone, can't shock it. But that's where we have this new technology of the ultrasound. So if we can't see a stone on x-ray, then we can always see it on ultrasound, and that allows us to break apart that stone. Almost every single stone out there can be seen on CAT scan. Almost every single one. Some of them can't be seen on x-ray. Almost all, I'm going to say a lot of them, almost all of them can be seen on ultrasound. Blood thinners is a challenge. It's not a contraindication, but it's a challenge because we got to get that person off the blood thinner and then back on the blood thinner. Pregnancy, I'm not going to shock anyone that's pregnant. I also don't shock women when the stone is down in the ureter by the ovaries, because there's some data that you could injure the eggs in the ovaries. Aneurysms, like an aortic aneurysm. I actually just had a wonderful patient the other day who's got a small 3-centimeter aneurysm, and his stone is right next to the aneurysm. I can't shock that. That person needs ureteroscopy. The morbidly obese, my table has a weight limit, and if you're too heavy, unfortunately, we can't do Shockwave for that person. So let's talk about some cases. I got some stuff here, some cases that I have. So this is a person, 62-year-old male, no symptoms whatsoever. He's got a little bit of microscopic blood in the urine. In other words, he went to his family doctor, his internist. He had his annual screening, and lo and behold, there was microscopic blood in the urine. He comes to our office, and boom, look at that. He's got a stone. That's a big stone. I'm not sure if I can get you to see that on my image here. I might be able to. Oh, look, I can draw. Look at that. So that's a big stone. That's at least 15 millimeters, maybe even bigger. And so what am I going to talk to this person about? If I look at the x-ray, this is the kidney shadow here. And so it's sitting in the bottom of the kidney. This is the upper part of the kidney. This is the middle part of the kidney. This is the lower part of the kidney. So what are you going to do? I can shock it. It's mostly going to require multiple shocks. I can go up with a camera, do what's called ureteroscopy, play asteroids with the laser. Percutaneous surgery, that's where you go through the back, and I literally grind up the stone through a camera and pull it out. And or sometimes just do nothing. Some people don't want therapy. They just want to take their chances. I don't remember what happened with this guy. I think there's a lot of ways of handling it, and each surgeon and each patient's going to have their own things. Personally, if it was me, I would put a stent in and I would shock this patient and see how it goes. If it goes nicely and this sucker breaks up really well, I may have to do a second shockwave, but I can always do ureteroscopy later and go and laser that stone and pull some pieces out with a basket. So this would be an example of someone who needs probably 2, if not 3 procedures. Let's see if I can get my page to change here. There we go. All right. Oh, I got to delete this. Holy shnikes. There we go. All right, so here's another x-ray. This x-ray is a little different. It just didn't photograph very well. 60-year-old male with a history of stones, has recurrent stone disease. This is a patient who had ureteroscopy, laser lithotripsy, and a stent 3 years ago. He's been doing fine. He comes to my office once a year to see how he's doing. His ultrasound showed a progression of a little stone. And there's a cluster of stones here in the bottom where the arrows are pointing. The overall burden is about 1 centimeter of stones, but this is actually probably 2 or 3 stones sitting on top of each other. So what are his options? Shockwave, go up with the camera and laser it, percutaneous surgery, send him to Six Flags, get a roller coaster ride and see if those things will free up on their own and pass. This patient actually tried to do a month of homeopathic stuff to dissolve the stone. Listen, I wish we can do that for people. It didn't work. His follow-up ultrasound shows the stones didn't budge at all. And so to me, this is a perfect candidate for someone for shockwave. That way they can avoid the dreaded stent. After the shockwave and we grind this thing up, we would have them do these things called lower pole exercises. That way they can kind of drink a lot of water. They kind of hang over their bed for a couple of minutes and try to get the little stones to pass. Next slide. There we go. So here's a little video of what a shockwave looks like. I'm going to hit play. It's only a couple of seconds. So that's shockwave. So here's the x-ray. Here's the vertebral bodies. This is the crosshairs. So we're able to pinpoint exactly to where the stone is. This dark area here is the stone. This area here is a piece of the stone that broke off. So we will periodically watch this x-ray. We don't x-ray the whole time. That's not smart. You'll turn into Chernobyl if that happens. But we image it periodically and we watch the stone break apart. And that's exactly what we saw here. Another case. Hopefully you can see this little picture here. There's a stone right here in the ureter. So this is a 74-year-old male, shows up in the office with blood in his urine. So in other words, he's seeing it. He's got some back pain that radiates to the front. He gets a CAT scan. The CAT scan shows a 5-millimeter stone in the middle of his ureter. So if I drew my pictures again, let me see if I can draw my pictures again. His kidney is here. His bladder is here. The tube, and then this would be the inner part of the kidney. Let's see if we can draw it like this. And then his ureter is going to be like this. So this is what we call the mid to upper ureter. And what happens is when the stone gets stuck, the ureter swells. The inner part of the kidney swells. We call that hydronephrosis or water on the kidney. The patient gets pain. He goes and vomits in the corner and then runs to the emergency room. So what are his options? It turns out this is the guy with the aneurysm. He had an aneurysm right here. And so I'm not shocking that guy. I can hurt that aneurysm. So this is a person who's been on medications. And as of the other day, his stone, after 3 weeks, has moved to down here. It is ready to pop, but it's too big. I'm going to go in and fish it out with ureteroscopy. I do have partners that would shock this. Personally, that's not my thing to do, but it can be done. So if I did have a patient that says, I don't want to stent, I would just be very open and honest, tell them the statistics of the stent and what that means. And then we take our chances. We know the statistics and we can try to do shockwave. Personally, I do ureteroscopy on this, laser it, pull it out with a basket, and then I put a stent in. And then 1 week later, we take the stent out in the office, or actually in our surgery center, excuse me. Let's see if I get the next slide. Yes, next slide. Case number 4. Let's go back to case number 1. This patient decides to wait on his stone, but 6 months later, it decides to pass. He shows up into a emergency room. He is on vacation because, like I said, stones happen at the worst time. He's in somewhere in the Highlands, North Carolina. This is a true story. And he is in a hospital where there are no urologists. True story. He gets transported to another hospital where there are urologists. He gets stented emergently because he's infected. And over time, the stent eventually, not over time, but the stent goes in, and then the stone is now sitting here. I know it looks a little different. That's just because of the property of the x-rays, but the stone is now in the proximal ureter. So if I add to the picture here, the kidney is here. This is the inner part of the kidney like this. The ureter is here because that's where the stent is. And the stone got stuck in the proximal ureter. So what we did is we actually brought this patient back to our center. He called me and said, I need you. I said, I know, I'm here for you. And we did a shockwave on him. And we were able to get this guy out of trouble. And I think he's doing just fine now. I think I got another one here. Oh, let's talk about stents, right? So stents are made out of polyurethane, which is a medical plastic, if you want to call it. They have what's called a pigtail. That's what these arrows are, and that prevents it from falling out. So it straightens out. It's soft, but when you deploy it, it curls up on each end. We pass it with a cystoscope, so you need to be under anesthesia for it. But stents are not fun. People know about their stents. It has side effects: urgency to urinate, blood in the urine, burning with urination, pain in your back. So in other words, when you urinate, the stent's going to move a little bit. Urine is actually going to shoot up the stent and go into your kidney, and your kidney is going to feel that, and it's going to cause pain. It can cause bloating and constipation, and the stents stay there until the stone is gone. That's the downside. People hate stents. If you talk to anybody, they will be able to remember whenever they've had a stent. All right, I think I got one more here. Let's see here. Hold on. Let's go back. All right, 24-year-old male with a family history of kidney stone develops right flank pain and vomiting. Stone was in his ureter. He had a CAT scan, went to the emergency room with the CAT scan, went to the emergency room and got the CAT scan. It shows a stone stuck in the upper part of the ureter. I went in, did what's called a ureteroscopy, the laser lithotripsy. That's where I play asteroids. I broke the stone up, and then I put a stent in. But this guy's got multiple stones. This is the stent right here where the arrow is. He's got a stone here. He's got a stone here. So if I draw the picture like I was doing before, his kidney is like this. This is the upper part, the middle part, the lower part. This is just kind of the way his anatomy is. And so what do? What am I going to do with this guy? He's got multiple stones. I've already operated on him. Let's see if I can get this to work. Oh, I got to exit off. Excuse me. So what we did is I left the stent alone. I brought him in. I shocked the other stones, and I was able to divide up the shockwave. I think I did 1,500 for the upper stone. I did 1,000 for the lower stone. So it all adds up to 2,500. And what I did is I took his stent out that moment. Why? This poor kid was miserable from his stent. Miserable. Once the stent came out, his road to recovery got dramatically better, and he was able to pass all of the fragments without any further surgery. Oh, I guess I got another one. 60-year-old male, CAT scan for GI issues. It shows multiple stones. He's got stones on the left. He's got stones on the right. What am I going to do? Is he going to have 4 shockwaves with me? Is he going to have a stent? Is he going to have ureteroscopy on both sides and laser on both sides? Can I treat both sides at the same time? These are the dilemmas that we have. So personally, what I would do for this person is I would probably bring him into my OR. I would put stents on both sides and then shock the left kidney. That's the least of his burden. And I think I can get that side one and done. A week or two later, I would bring him back in, and then I would take the left stent out. So on x-rays, we do mirror images. So this is the left, this is the right. And so I would do the left stone first, and then a week or two later, I bring him back, and then I would put a camera into this kidney, and I would laser a bunch of these stones. I would put the stent back in. This stent comes out, and then I would just keep working on these stones until he becomes stone free. That's probably what I would do without having more thought on the situation or seeing what his thoughts are or her thoughts. Let's click this off. All right, so that's my talk. We did that. It's pretty good, 35 minutes. So once again, I am Dr. Mark Greenstein. I'm a urologist here in Sandy Springs, Georgia with Advanced Urology. Here's our office number. Here's our website. We do have a YouTube channel. This video will be on the YouTube channel in a couple of days. We have a wonderful person named Jamil. Shout out to Jamil for helping us out with all this technology. I am more than happy if anybody wants to put some questions into the chat room. I leave that up to you. I usually cover a lot of this stuff here, but please feel free if anybody wants to put a message in. Okay, no big deal. Very straightforward. I want to thank everybody for participating. If you ever need something, just give us a call at the office. I'm going to sign off. Please have a good night.